distal radius fractures, classification, Fernandez classification, and Frickman classification. Fernandez classification, 1 is bending, 2 is shear, 3 is avulsion, 4th is high velocity, and 5 is combination. So bending, shear, avulsion, high velocity, and combination and compression. Fernandez Frickman classification, type 1 is transverse metaphyseal fracture. It is extraarticular, Cooley's or Smith. Type 2 is type 1 with ulnar starlight. Type 3 is involved radiocarpal joint, Barton or reverse Barton. Type 4 is with starlight. Type 5 is involved Drudge. Type 6 is with ulnar starlight. And type 7 is comminuted. And type 8 is with ulnar starlight. Remember the acceptable criteria: 11, 22, 11. Volar tilt normally 11 degrees. Volar tilt normally 11 degrees. Radial inclination normally 22 degrees. And radial height normally about 11 millimeter. Treatment guided by the parameters: fracture pattern, stability, patient age, and functional demand. Acceptable volar tilt, neutral. Radial inclination, about less than 5 degrees. Radial height, less than 5 millimeter. Ulnar variance, -1 millimeter. Intraarticular displacement, less than 2 millimeter. Acceptable angulation in children, less than 8 years, 20 degrees, more than 8 years, 15 degrees. A column concept, there are 3 columns: medial column, intermediate column, and the lateral column. Hutchinson fracture, Schoeffer fracture, is an oblique fracture of the radial starlight. It's a dorsiflexion and abduction injury. Scaphoid forcibly impact on the radial starlight. Die punch injury is a depressed fracture of the lunate. Aim of any intervention is restore: number 1, restore radius alignment. Number 2, restore congruence of radiocarpal and radioulnar joints. Number 3, removal stent should be used for undisplaced fracture. Number 4, adequacy of reduction is patient specific. Number 5, low demand experience, no functional limitation even with considerable displacement. Assessment of instability in fracture in adults, Nesbitt et al., 2004, LaFontaine criteria. More than 3 risk factors, unstable. Number 1, dorsal radial comminution, more than 50% palmar or intra-articular comminution. Number 2, dorsal angulation, more than 20 degrees. Number 3, initial displacement, more than 1 centimeter. Number 4, ulnar fracture. Number 5, radial shortening, more than 5 millimeter. Number 6, osteoporosis. Out of these 6, if more than 3 factors, the fracture is unstable and deemed necessary to have intervention. At 4 weeks, 54% of those classified as unstable failed to maintain adequate reduction. Risk of redisplacement, more in elderly, especially more than 60 years of age. Management of distal radius fracture, both guidelines. Number 1, document the mechanism of injury, skin integrity, assess the circulation, sensations, and document it. Number 2, PA and lateral view of the wrist. Number 3, manipulation under regional anesthesia, not hematoma block. Number 4, early mobilization in stable fracture with removable splint. Number 5, if POP used 3-point molding, no forced palmar fraction, consider removal of POP at 4 weeks time. The palmar flexion elevation, coronal lower position not acceptable. Number 6, more than 65 years, non-operative treatment unless there is significant deformity and neurological compromise. Less than 65, consider ulnar variance, intra-articular step-off, dorsal tit, and patient need while considering surgical reconstruction. Number 7, volar displaced fractures are unstable and should require ORAEF. Number 8, if fracture displacement is reduced close manipulation, consider K-wire. If not, ORIF. Number 9, surgery done within 72 hours for intra-articular fractures and within 1 week for extra-articular fractures. Number 10, if redisplacement following manipulation, operative intervention within 72 hours. Number 11, repeat radiograph at 1 to 2 weeks after injury when it is thought that the fracture is unstable and when subsequent displacement may lead to surgical intervention. Number 11, avoid radiograph when the POP is removed is required unless there is a clinical concern. Number 12, fracture liaison services provided. Number 12, all patients receive information regarding expected functional recovery and rehabilitation and advice regarding normal activities. Indications for surgery, radial shortening more than 5 mm, dorsal tilt more than 10 degrees, intra-articular displacement more than 2 mm. When I'm addressing these patients, I will discuss regarding patient factors and surgery factors or the fracture factors. Regarding the patient factors, I would consider patient age, dominance, functional activity, comorbidities. Regarding the surgery factor, I would like to consider the LaFontaine criteria, that is radial the displacement, radial comminution, angulation, displacement, ulnar fracture, shortening, and osteoporosis, and then decide a plan. Age is also important to consider. I can also document and discuss draft trial. Regarding the principles of fixation, number 1 principle, articular reduction. Number 2, restore anatomical relation. Number 3, regain motion. MUNKY intrafocal Kapanji interfragmentary. Bolster on the wrist to maintain volar flexion while wiring. BMJ Costa et al. Draft trial, distal radius acute fracture fixation trial. It was a multi-center trial, extra-articular fractures in a multi-center RCT with percutaneous K-wire versus locking plate. ORIF was for dorsal displaced fractures with more than 3 cm of radiocarpal joint. They found no difference in functional outcome in patients with dorsal displaced fractures of distal radius treated with K-wire or volar plate, including intra-articular fractures. The caveat and the problem is number 1, excluded displaced intra-articular fractures and volarly displaced fractures. Number 2, surgeon selection bias was present. Number 3, follow-up of only 12 months is not long enough to assess the risk of arthritis. Another surgical option is external fixator, is at the radius to the second metacarpal. It's a bridging sort of component, 45-degree radial inclination, radially inclined in index metacarpal to avoid extensor tendon, and it concepts on the ligamentotexis and can be supplemented with K-wires. Over distraction can lead to stiffness. Another type of ORI is variable angle polyaxial two column LCP, can use K-wire to correct the radial inclination. Water plate, uh, the risk is fracture of the flexor pollicis longus. During the surgical, the importance is to avoid watershed area, most volar margin of the radius, closest to the flexor tendons. Uh, Distal volar lunate fragment, site of origin of volar radiolunate ligament is important. Displacement volarly will allow lunate and carpus to sublux volarly. Standard volar plate cannot capture these small fragment pieces without risking tendons, so we need to have fragment specific plate. Dorsal plating can cause extensor tendon rupture. Keating et al. Immobilization after surgical intervention, JBGS 2018. Immobilization comparing the effect of 1, 3, and 6 weeks of immobilization in function in pain after ORIF of distal radius fractures, 1 to 3 weeks of period of immobilization of distal radius improve early function versus 6 weeks. So it's optimal to immobilize the patient for 1 to 3 weeks. Complications: malunion, radial shortening, ulnocarpal abatement with and dorsal angulation. Ulnocarpal abatement can be treated by ulnar shortening osteotomy, dorsal angulation with open wedge osteotomy with bone graft, carpal tunnel syndrome in about 10% cases, EPL tendon rupture because the watershed area at the level of listed tubercle, damage at the dorsal fragment or the screws. Prime repair is sometimes not possible because of pure tissue quality. Transfer the EIP by the 3 incision technique. CPRS is a risk, complex regional pain syndrome. 500 milligram of vitamin C can be advised. Stiffness, superficial radial nerve injury is possible with K-wire or X-fix. FPL rupture if the plate is more than 2 mm from the watershed area. Regarding the EPL rupture in lacerations, if EPL laceration cut is below MCP, the adduct it is lying between the adductor pollicis and abductor pollicis, and keep it away from the retracting proximally. If above, if the EPL cut is above MCP, it will go proximally and would be lying in the synovial sheath via extensor carpi radialis tendon.